Good afternoon, everyone. I guess it's officially noon, so afternoon. I'm just seeing people trickle in, so we'll just get started in about a minute. Give it another, I don't have a stopwatch, but I'll count 15 seconds in my head and then we'll get started because I know we're in for an exciting presentation today with a lot of information. So I want to make sure we have time also for questions at the end. All right, so welcome everyone to our first PDN webinar of the new fiscal year. I know I sometimes count in calendar year, now fiscal year, because that's how we plan a lot of our work at PCMCH. So before jumping in and passing it over to our presenter today, I'm just going to do a land acknowledgement and a few housekeeping items, and then I'll pass it over to Alana. I would like to begin by acknowledging my sincere gratitude for the opportunity to work and live on this beautiful land that has been occupied by First Nations since the beginning of time. This land on which PCMCH operates is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe peoples. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13, with the Mississaugas of the Credit. Toronto is now home to Indigenous peoples from across Turtle Island. PCMCH recognizes that Indigenous practices of health and well-being have been in place in this territory since the beginning of time and are maintained to this day. We are committed to honoring and improving our knowledge on these practices. We recognize the harms and mistakes of the past and make meaningful steps toward reconciliation by building and improving our relationships with First Nations, Inuit, and Métis people. Next slide, please. So just a few reminders before handing it over to our presenter today. You'll be able to post questions using the Q&A function on Zoom, or you can use the raise your hand function. So all participants right now are automatically muted, but when you raise your hand, we'll give you permission to speak and then unmute you to ask your question. We'll do our best to save some time at the end for questions and discussion. And without further ado, really happy to hand it over, next slide please, to our presenter today, Alana Chambers, joining us from beautiful Kelowna, BC. Alana is a registered dietitian, certified diabetes educator, and certified pump trainer. She has worked and volunteered in various diabetes settings across Canada and now focuses on technology training and education for both people with diabetes and healthcare professionals. And I know some of you joining today may have seen Alana present at the Sick Kids Diabetes Day in the fall, and I was there and really enjoyed her presentation, so I invited her to our PDN webinar today. Alana has been honored to actively work on recent Diabetes Canada initiatives, including the DIY Automated Insulin Delivery Position Statement and the 2025 Clinical Practice Guideline update on glycemic management of type 1 diabetes across the lifespan. Having lived with type 1 diabetes for over 30 years, she has learned that daily management requires a blend of knowledge and tools, along with creativity, support, and self-compassion. And I'll hand it over to you now, Alana. Welcome and very glad to have you here today.
Great. Thank you so much, Leslie. So I'm just going to get myself set up here before I get rolling. And we hopefully does that look good?
I think we see your notes, so I think you have to put it in slide.
Earlier. Sorry, just a second.
It's okay.
It's not letting me swap this. Hang on. Right when we always think we have technology figured out. Hold on. I love when I do a technology talk and I get my own technology goofed around a little bit. It's not hard to do. So hold on, bear with me a second because that somehow got swapped on me. All right,
Yeah,
are
now
we good
we
to go
can see it.
now?
Yes,
Awesome. Thank you so much.
excellent.
Sorry about that. All right. So thank you, Leslie, for reaching out to me to talk about this. This has been, we did our position statement. It was published in 2023. And, I was just sharing before we began, it's been really incredible to see this DIY looping support really get embraced in the healthcare community. So I thank all of you attendees for requesting to learn about this and for showing up today. So before I get started, what I would love to do is just have each of you kind of self-reflect. And I want you to think about when it was that you first heard about DIY looping. And I want you to think about how that made you feel as a healthcare professional, especially, even if you live with type 1. But, did you feel nervous about it? Were you like, oh my goodness, this sounds really scary. This could be dangerous. Were you excited about it? Did you, see the eyes light up of people who were learning about this and wanting to use it for the first time? Maybe you were confused. Maybe you had mixed emotions. And I will very openly share that when I heard about DIY looping for the very first time, it really scared me. Having come from working in the insulin pump industry, I spent almost 10 years back working at Animas. And I knew about the heavy regulation that went into the various diabetes technologies, especially around insulin delivery. And I thought, how is this even possible? How are people doing this safely? So I definitely have been there, right? And I have learned a ton since then. My eyes have been opened. I've had personal experience with this system now, which, I would have never thought that when I first learned about it. And am now looking at it through the healthcare professional lens as well. So I really hope to kind of open your eyes, hopefully a little bit, and have some practical learning here with how to work with this in practice over our session. Before I begin, here are my disclosures. A lot of work with the diabetes technology companies, and really excited to get my what was just my private practice, which is Type 1 Journeys, up and running, but there will be a lot of other education pieces coming with that I'm really excited about coming soon. So over the course of this next 45 minutes or so, we're going to dive into the do-it-yourself automated insulin delivery position statement and user guide, and really getting into, what are some of those pieces that we can put into practice? How do we optimize people's settings? How do we help guide people through their adjustments? And where do we draw the line between this do-it-yourself side versus the support that we still need to be offering to families and to individuals living with type 1 diabetes? So, and we'll hopefully have some time for questions at the end as well. But before I go there, I cannot leave out a mention, at least, of our brand new chapter in the clinical practice guidelines on glycemic management across the lifespan for people living with type 1 diabetes. And we have not had an update on anything related to insulin delivery since 2018. And that was back when we had an adult chapter and a pediatric chapter. We have realized now that there are way too many similarities. It didn't make sense to pull these apart. And so we did put them together. This was a massive undertaking. An enormous thank you to Dr. Alana Halperin and Dr. Brandy Wicklow for leading the way on this. But definitely insulin delivery was a very large piece of this guideline and something I was very excited to be a part of. And we very carefully went through to review the evidence to make sure we had a clear understanding of what our recommendation would be and for who we would recommend which therapy for. And we have come a long ways, although we recognize that regardless of, people using basal bolus injection therapy of different amounts, pump therapy, predictive low glucose suspend, automated insulin delivery, we absolutely recognize that there's a lot of personal choice in this. And people may choose things based on, their own experiences and their own wishes. But we were able to come up with a very, very clear recommendation that automated insulin delivery should be used by all individuals, regardless of age, regardless of stage of life, all individuals with type 1 diabetes. And what's really exciting about this versus I think what we see in the guidelines in other areas around the world is that yes, we have these glycemic metrics that are grade A level 1A recommendations, A1C, time in range, hypoglycemia, but then we also have all these person-reported outcomes, fear of hypoglycemia, diabetes distress, quality of life. And to be able to put a grade A level 1A evidence around that is absolutely incredible. And so we may have people choosing to use these systems to improve glycemia or quality of life or both, right? And those are all valid reasons for using one of these systems. Also, important asterisks here for those willing to wear it and operate it. It isn't for everyone, or some people may not quite be there yet, and that is okay. But we do need to make sure that we're having these conversations with people around using AID. So it's really exciting in Canada right now that we have 2 new automated insulin delivery systems to the market. So these are now our 4 commercially available automated insulin delivery systems. And if you're anything like I am right now, my head is kind of spinning, learning about all these different systems, all these different algorithms, what setting can we adjust in which system, like what might be the right fit for someone, how do we have these discussions with people? It definitely is complicated from our side when we have to work with all of them. But through the lens of someone who lives with diabetes, I think that this choice is absolutely incredible, because what we know is that no one algorithm is the same, and there are going to be different reasons why someone may choose one system over the other. So the question we may be left with now is, where do the DIY systems fit in? Right? We may say, okay, we've got all these commercially available systems. Is DIY something we should still be supporting? Can't they just pick one of the approved devices? And where do we draw the line with the level of support that we offer for people who may be choosing to use these DIY systems? Where do we have that discussion? And, I'm looking back, I'm really thankful that we had Diabetes Canada say to us that, when we knew we needed to do some updates on insulin delivery recommendations, they had this idea that maybe we should back up a little bit and make sure that we have a position on the do-it-yourself systems beforehand. And so that is why this publication and this work was done ahead of the guidelines, so that we could feel comfortable and confident in saying, is DIY a part of this, recommendation or not? And it is. So that is kind of how this project evolved. So this was out now 2 years ago. Most of you have hopefully seen this. If you haven't, it's openly available online. We will send the links after the session. But this was really important work to be done just to ensure that we had some clarity around where we stood on the do-it-yourself systems. So before we dive into this, I certainly recognize that we have different levels of comfort. And so I would just love to get a gauge from the group on, where do you sit right now? How comfortable are you supporting someone, a family, if they come in and they're saying they want to loop or they are looping? Where do you kind of sit on this spectrum of comfort? Is it maybe you don't quite feel comfortable yet supporting them, kind of let them do their thing? You try to help them with their settings. If you work together with them to adjust their settings. And some of you may have really learned a lot about this, and you feel quite confident supporting people as they optimize the use of these systems. Give you a second there. Curious to see where this lands. Do we have those results up? Not seeing them. There we go. Okay, so we have quite a wide range. And this has been really interesting. I've had this polling question up over actually the last couple of years, and I've loved watching how this evolves. So we still do have some of you that are just learning, maybe haven't gotten enough education on this yet, all the way up to, 21% of you feeling confident. And then a number of you kind of sitting somewhere in the middle. And so that's, kind of to be expected. So thank you for coming today to learn a little bit more. So let's start at the beginning. What is a do-it-yourself automated insulin delivery pump system? So before we had commercially available systems, if we back way up to the days where all we had was an insulin pump and a glucose sensor. And the diabetes community could see that the innovation was incredibly slow. It takes a very long time for a company, for industry, to actually do the research and everything that is needed to eventually put a product on the shelf that we're able to purchase. And so they said, listen, we've got an insulin pump, we've got a glucose sensor. Clearly, we have the pieces that we can put this together. And so if you put together a group of incredibly passionate people with a purpose, most of them living with type 1 diabetes or being a caregiver of a child or a loved one living with type 1 diabetes, and if you put them all together, we had this incredible movement that was born. And this is the hashtag We Are Not Waiting, which is still out there today. And basically what they said is we are going to do what we see we're able to do. And we don't want to wait for industry to eventually put something to the market. We see the possibility, and we don't want to wait for this anymore. So basically what they did is they took an approved continuous glucose monitor, an approved insulin pump, and they figured out how to connect them together. Now, these initial setups were very cumbersome, very clunky. These were before the days of, good and reliable Bluetooth technology and ways of devices communicating with each other. So that's why we see all of these extra pieces in the middle. And then over time, though, what we saw was that they were able to turn Loop into a smartphone app. And there would be a linking device. So this is the orange link. There was the Riley link before that. That was basically the bridge. So it allowed, the phone would connect to the orange link, which would then connect to the pod or the Medtronic insulin pump. Today, with the Dash pods, the phone is able to connect directly to the pod. They have managed to figure that out. So we've really watched this evolve quite a bit. And there's still many reasons why people are continuing to use these devices, even though we have, quite a variety of selection available today of commercial systems. And why families are choosing to do this is a number of reasons, and that reason is different for every individual. But in a survey back in 2022, what we saw was that a lot of it was around transparency. So as we get into the app, you will see that it is very clear what the system is doing in the background, and people feel a little bit more confident in that. Everything's not hidden behind, these proprietary algorithms behind the scenes where you're not really sure what's happening. So they feel kind of that ability to trust their system. The interoperability, being able to flip between the device they want to use, supporting that open source software, recognizing that updates are available fairly quickly. And for many people, it's based upon availability and affordability. So I live in the province of British Columbia, where we have not had provincial coverage for automated insulin delivery pump systems. Our pharmacare system does not recognize that as a category. So we have a mixed match of coverage between which sensors are available and which pumps are available for provincial funding. So in our province, we've had many, many people uptake to using these DIY systems because they can't get coverage to get all the pieces put together for a regular system. And then some people really feel it's safer. Absolutely. If you follow along, I'm going to give some of the different support groups that people belong to, but it is an incredible community of people that made this happen and that continue to make this happen. So people do not feel they're doing it alone. It's do it yourself, not do it alone. They feel very supported and like they've become a part of a diabetes community. It's pretty incredible to see. But of course, we have to do our due diligence here and check and go, well, is there actually evidence to support the use of these systems? And it was really exciting seeing some of these early papers start to get published. And this list has grown and continues to grow. And what we see in all of these studies looking at these systems is that people are meeting and exceeding, these are their A1Cs, all meeting or exceeding those A1C targets and time and range targets. Right towards the end of our publication, we saw the first randomized control trial published, where again, we saw, meeting A1C, meeting time in range targets in both kids and adults living with type 1 diabetes. And what's really important is that we did not see an increase in adverse events. So there was not an increase in hypoglycemia, and there was no increase in DKA or other adverse issues, which is, I think, what initially scared many of us about it. Is this safe? And so, the evidence points in a positive direction towards that. So that really did lead us to feel comfortable saying, yeah, we do need to support people in using this. There is evidence to support the use of these systems. And so as healthcare professionals, we certainly do have some ethical obligations. So unanimously as a group, we recognized, and I think everyone here will recognize this as well, that we absolutely need to be respecting patient autonomy. I don't know any other disease state where so much onus is put on the person who lives with the disease. In type 1 diabetes, we are self-titrating a, very, very challenging medication where, as you all know, one misstep can lead to a catastrophic result. And we are doing this manually ourselves every single day, every time we eat, every time we exercise, every time we go to bed. And so when we recognize the risk that comes with taking insulin as a whole, we can appreciate that, layering in automation is actually adding in an extra safety net, right? You think about how many times have you heard someone on multiple daily injections maybe mix up a long-acting and a short-acting insulin pen? I've heard that story several times, right? Or somebody miscalculating an insulin dose or dialing up the wrong number of units in their pump. I've seen decimal points mixed up in basal rates. And so we do see error in diabetes everywhere. But yes, when we put on automation, number one, we have a CGM working, right? These systems all require the use of CGM. There will be that low alert and a high alert if there's trouble. And then especially on that hypoglycemia end, if something does happen, we have that suspension that's going to kick in to help minimize or prevent that hypoglycemic event. So we certainly see that safety that comes with these systems. Also, as healthcare professionals, we do have an obligation to inform people of all evidence-based treatment options. That includes DIY looping, and then supporting them with the use of whichever therapy they are choosing to use. So this is what allowed us, and with the support of a lawyer we had on this as well, this allowed us to then say, yes, indeed, we need to have these discussions with people. We are able to support people, and we actually should support people if they're choosing to use these systems and not turn them away. So that's that. Easy enough to say, hey, we should be supporting people who choose to loop, families that choose to loop. Well, we also can appreciate that with our commercially available systems, we have support from industry. So you have reps and clinical specialists that come around and do training and education to help you feel comfortable and make sure you have the tools and the resources to operate each of those individual systems that are out there. With the DIY systems, you don't necessarily have someone coming to your clinic to do a lunch and learn. So thank you for hosting this today. So we were really thankful that Diabetes Canada did support us in publishing this healthcare practitioner's user guide so that you would have kind of that key information at your fingertips that you need in order to support people who choose to loop. So the QR code is here. You can scan that. That is openly available online, and we will send out the link after the session as well. So this really kind of goes through everything from having that discussion at the beginning when they're trying to make their choice in what system they want to use, right up to fine-tuning the settings and getting into using Night Scout and Tidepool. So let's start at the beginning. All right, that discussion around therapy choice. So with which families would you consider discussing the use of loop? It'd be nobody, maybe wait till they ask. Is it those, you can choose as many as you want here, those who are motivated to use it and build it, those who are tech savvy, experienced pumpers, experienced AID users, those who ask about it, all individuals with type 1 diabetes. What do we think? Curious where the answers come up on this. Okay, we've got a really cool mix here. And again, I think this has really evolved, right? I know if I go backwards to when I first learned about loop and I wasn't sure if I was supposed to be talking about it, there was a time period where I thought I can only address it if I get asked about it. That was kind of, so those of you in this, 34% of you, that was my initial thoughts on that before we got into this important work. Got a lot, those who are motivated, those who are tech savvy, experienced pumpers, a large percentage of you, though, saying all individuals living with type 1 diabetes, which is really incredible. And that's really where we've moved with the guidelines now, is we have gotten out of this list of requirements for who is, I guess you could say, deserving of using diabetes technology. In the early days of pump therapy, there was a long list of criteria on who would be a suitable candidate for a pump. Motivation was often a big thing that was in there. And what we have now said is that, hey, guess what? Anybody has the ability to do well on these systems. Now, when it comes to DIY, the big difference is they have to be able to actually build the system themselves. Now, somebody may have the technical skills to do that. Maybe, they've got a software background or they are that really techie. But I've met many individuals who have, a spouse or a partner or a family member or a neighbor who's willing to help them with that, and they can pull that together kind of on their own. So I think we have to just be really careful to check the biases at the door and make sure that we allow them to make that choice. Because really, it's kind of giving people this menu of, you have the option of giving your insulin by injection therapy in a couple of ways, by an insulin pump, by AID, and then to say, this is what we're recommending right now, or if you're willing to use it. And we get into that, we have these commercially available systems, and we also have these do-it-yourself, build your own app systems as well. And it is important that through this, discussion on therapy choices, that we do bring it up. Because if we fail to mention this category when they're talking to us about what pump they want to go on or what system they want to go on, chances are most people go home to Google to kind of do a little bit of research on what system they want. And if they go home to Google and they hear about looping in the online space, what does that do to kind of our trusting relationship with that family over time? Are they going to question, hey, they didn't bring this up to me, will they support me with it? There's a lot of stuff online out there about, people in other areas of the world not being allowed to go to a clinic or being pushed out of a doctor's clinic because they're not willing to support them in using a DIY system. So there's a lot of gray out there. And so I think it's really important that even just mentioning it at the beginning allows them to know that you would be on board with supporting them in the use of that. And that's a really important piece, knowing obviously that it's not for everyone. Now, even if you're one of those people who is not quite yet comfortable with these systems, you need to remind yourself that there's a lot you probably do know from your other work in the diabetes space. And a huge piece of our diabetes education still remains around those fundamental pieces of diabetes self-management. Everything here from sick day management, highs, lows, all of those things, basics of CGM, basics of pump therapy. That use of that automated system is really just the tip of the pyramid. So if you're not, you're still learning here, don't forget the enormous impact that you can still have on people as they kind of go through their journey with looping around the core elements of diabetes self-management. The other thing I will point out here is that specifically with this system, it is heavily encouraged that when people set up this system, that they start in what we call open loop. So they set it up without automation, because it is really important that those pump settings are refined, not necessarily perfected, but they should be roughly in the right ballpark before they start looping. So you can get people all the way up to this point here. And then as we get talking about this, that getting it started then becomes just a switch for them to flip on after we've done this core work with them before they begin. So as we get into talking about these systems, there are, in our position statement, really what we were covering was these three systems that had some level of evidence at that time. So that was Loop, Open APS, and Android APS. for the sake of today's presentation and not to confuse people, I am going to focus on Loop. That is the most widely used system, especially in Canada. This is the one that works with an iPhone. You may see some families still using Android APS, which works on their Android. I'll have a few screenshots of that, but I'm going to be focusing on Loop moving forward from here. So when a family is interested in starting looping, where do you go with that conversation? Where do you send them to get started? So probably the very first place I would send somebody is to this Looped Facebook group. And to me, this was a bit of a foreign thing to go, oh my gosh, we're sending people to Facebook. But just to be reassured that that is a heavily moderated group. They do not give medical advice, but this is where we get that sense of community, which is what looping is really all about. It's a collaborative effort. So I would send them to the Looped Facebook group, and they're going to very quickly learn there what is required of them to move forward in this journey if they choose to use Loop. And they will help guide them there to the appropriate. So Loop Docs is for Loop. This is this step-by-step website that's going to walk them through exactly how to build that app, what they need to build it, the pieces, the requirements, what type of pump they need. All of those pieces are all on the Loop Docs. The one thing I will say about this group is that they definitely, very much so value the DIY side of do-it-yourself looping. So they are not there to do it for people. And so you will often sometimes see comments where someone will go, well, what pump do I need in order to run this? And they'll go, you know what, go and check the Loop Docs. So there is this expectation that people are doing their own homework. And we did heavily talk about this and say we absolutely do not expect any healthcare professional to take on the responsibility of building someone's app for them. This is the do-it-yourself side to this. So it is important that they do go through these steps of learning how to build this app if they really do want to embrace this technology. And that's important because it's not just about getting the app on your phone to begin with. What if you need a new phone? What if your app goes down? What if you need to do a rebuild? What if there's a software update? Having gone through all of those steps of building it is going to allow them to support themselves moving forward. And it's pretty remarkable to kind of watch what happens to people as they go through that journey. That is a part of all of this. So not the responsibility of the clinician, okay? Make that very clear. I'll give a little shout out here. Loop and Learn is another great website. They do a lot of videos if you want to continue learning, especially as new versions become available. That's worth a follow. So if we get into kind of these systems, so here's the Looped Facebook group. So if they look up hashtag We Are Not Waiting, that's easy to find. I actually highly recommend that healthcare professionals join that group as well. That is very welcomed. You will learn a lot following along in there. And the Loop Docs really is where you find the answers to everything. So this does include the step-by-step guide of how to build the app. I would tell people, be prepared to set aside an entire day to doing it. It is detailed, but as long as you're willing to follow the instructions, it is definitely doable. It is all written out for you. But for you, this is actually a great place to go and look into the fine details around many of the settings. And if you're not understanding how something works, all of the answers are on there. And then same goes for the Android APS documentation website as well. Okay. All right, so let's dive into really helping people optimize their use of their Loop app. And this is where people are coming back and you may feel like, okay, which setting do I change in this system? How is this actually working? So that's what I want to get into here now. So as we're applying with all of these systems we have available now, it's really important that we take a step back and not get too caught up in some of the bells and whistles and the nice to haves of some of these systems. But what's really important for us to understand, especially as we're going in to adjust settings, is number one, how does this system actually calculate insulin delivery? And which settings are we able to adjust? These are your two most important questions to ask about any automated insulin delivery system in order to help optimize the use of them. And then we can get into, when do they get bumped out of closed loop? What do we need to educate them about to optimize their use? And then they're going to want to know a little bit about sensor compatibility and how to share the data as well. So let's start out with understanding how this algorithm works. And I'll try and do this as simply as I can. So basically what the system is doing is this little star here is where the current glucose is. And it's looking at the predicted glucose over that entire duration of insulin action time. So over the next 6 hours, where is that glucose predicted to go? And it is then going to take that predicted glucose and compare it to the target glucose and say, okay, we need to adjust the insulin. In this case, the predicted glucose is going to be below target. So we need to find a way to reduce the insulin by a certain amount so that that prediction comes up closer to target. And so it is then going to take those program basal rates, which act as the baseline, and it's going to either increase or decrease the insulin delivery around that. So this is the most comparable to the tandem control IQ system, where program basal rates act as the baseline. And in this situation, it's actually temporary basal increases or decreases around that baseline in order to help bring them back to target, the prediction back to target. They also can set up an auto bolus or set it up as auto boluses. So it'll either be temp basal increases and decreases, or it can be giving it as auto boluses. They work a little bit differently. We can maybe save that for Q&A if anyone has specific questions, but kind of the same core concept there, okay? And as I mentioned earlier, what people really like about this system is the fact that it's transparent and they can see what's happening. So one of probably the best advice I could give you is if you're learning about Loop, or if you feel experienced with Loop, when someone comes into your office and they're using this for the first time, ask them to show you their app and have them explain to you what they see happening on their app. They may learn through that process sharing with you, and you're absolutely going to learn as you listen to them explain what's happening. That is a wonderful way for you to actually learn together. So what you'll see, right at the top, whether this is the Android system or Loop, that green loop means that it's working, it's in closed loop. This will turn a very clear red if for some reason the system is offline. And they'll see their glucose, their trend arrow. And then here we see their glucose curve. So this is where the glucose is now, and that's where it's predicted to go relative to the target. It's keeping track of how much active insulin or insulin on board. And again, it's got that glucose curve in the background, so we know how long that insulin is going to continue to work with the total. This is like your IOB up here. And then we see very clearly on the screen what this what's happening with insulin delivery. So here, this 0 is the baseline. So that's the programmed basal rate that's running in the background. And how much is it subtracting or adding on to that programmed basal rate? And you can, I love that you see these bar graphs, much like we'll see on a Gluco report or a Tandem Source report or a CareLink report. But to see that in real time, you can very clearly see that you've been getting a large increase or maybe a small increase or decrease over how long. This little triangle here means that a bolus was given. And if they do have that auto bolus turned on, you will see several of those, but without auto bolus, you would just see that when they manually enter a bolus. And for the dietitians who love talking food, you also see the active carbohydrates in here as well. So very quickly on that home screen, you see a lot of information. And I know when I used Loop for the very first time, I felt like just monitoring my home screen, I was able to have a really good sense of what was working and what wasn't without even downloading. If you're looking at this every day, say, in the morning when you wake up and it's always decreasing in the morning when you wake up and you notice that trend, then I know my basal program is probably off. Or if I'm seeing, lots of increases every time I eat afterwards, maybe my carb ratio is not strong enough. So you can learn a lot just from watching that in the moment. Very, very clear display. Down at the bottom, these are all of your controllers. So we call this the caret. This is your bolus button. It's going to take you into the bolus menu. And probably for your sake, this settings button is one of the most important ones where you'll go in and find what their settings are. Okay. And then we'll get into some of these other guys here. So this is in the user guide with the legend. And like I say, I absolutely encourage you to get people to talk you through this. Okay, so next important piece is what settings can we actually adjust on this system? And we can adjust every single pump setting just like we can on a traditional or a dumb insulin pump. So we can change the basal rates, the insulin sensitivity factor, the carb ratios, correction range, the insulin model to a degree. They're usually a 6-hour, but you can change it slightly. The delivery limits, the suspend thresholds. You can also choose if you want it running in that temp basal only, where it's just working on basal modulations, or if you want the automatic bolus version, which is a little bit more aggressive. And what we need to remind ourselves of is that, this may look to us like, oh my gosh, this is complicated. This is a lot of settings that we can adjust. Like I mentioned, it's just like what we've been doing for years with traditional insulin pumps, except we have automation working in the background. So just because we can adjust basal rates doesn't mean this needs to be as much work as it used to be, because that automation is going to be making up for some of the variance that happens from day to day and throughout the day. So they do not have to be perfect by any means, but in the rough ballpark. We also have to remember that, in all of these studies that are done, one of the main reasons why people are choosing to use Loop is because they like the ability to be able to change all of these levers. And they have specific insulin requirements that they want to accommodate for. So that is, something to keep in the back of your mind. This isn't a bad thing. This gives people kind of that sense of control that many people are after, especially if they have specific challenges that they want to be able to manage. Okay, so of all of these pump settings that I just talked about, and I know there's been a lot of education from the various companies right now, so this might be starting to get a little bit foggy. Probably one of the most important questions we need to be asking ourselves is, which setting is probably the most important, or which setting could cause the most trouble if it's not fine-tuned? Okay, is it the basal rates, the ISF, the carb ratios, the correction range, the insulin model, delivery limits, or the suspend thresholds? Very curious to see what this group says. You can also think of this as, what is the strongest lever to pull? I love that terminology that's out there right now. What lever do we pull on the most, that has the most weight? Let's see what the group says. Okay, I see basal rates. Most of you are saying insulin sensitivity factor, carb ratio, correction range, and suspend threshold. Okay, I'm going to give you the final answer as we go through these. Okay, these do all play a role for sure. One holds more weight than others, but I think this is a pretty savvy group. Okay, so here's our correction range. So this is, I think, one of the major driving reasons why people are choosing this system, is because they can get as custom as they like, or almost as custom as they like with this. So there actually have been guardrails put in here now, different from earlier versions, where it does allow you to go from 4.8 to 10. But they can basically set this as a range, or they can set it as a single number. So they can do 5.5 to 5.5, and they can adjust that by time of day, but completely up to them. There's also this really neat little feature called the pre-meal override, which allows you to set a potentially tighter target. And ideally, that's what you're doing, a tighter target before the mealtime. And then what you would do before a meal is simply just tap on this icon. You can also do it from the Apple Watch, so just a quick tap. And you can imagine, if you have that target set a little bit tighter, what's it going to do? It's going to ramp up that insulin delivery in that pre-meal time period, basically kind of, helping to get some insulin on board and almost working as a bit of a pre-bolus. It can be really effective for some people. A lot of people really enjoy this. Once that bolus goes in, or after an hour, it will be canceled. So neat little feature people tend to like there. Now let's talk about the basal rates. So as I've said, multiple times, but I want to make sure it's well understood, those program basal rates act as the baseline. The temporary basals are increased and decreased around that programmed basal rate. So this is where it is really important that those basal rates are tested before starting Loop. Particularly, I know that I've definitely seen in many teenagers, but other age groups as well, where we have those basal rates falsely increased in order to make up for missed boluses around snacking or sometimes even lunchtime. So if those basal rates are compensating for under bolusing, not on Loop, we do need to make sure we get those back down to their true physiologic, closer to the physiologic basal rates, because we don't want to be getting, the system also kicking in on top of a falsely elevated basal rate. So if the pump ever, if the system ever fails, if the loop goes offline, if the sensor is not communicating, it will go back and it will just continue to program these basal rates. So what is nice about the system working off of those programmed basal rates is that we're kind of forced to keep those up to date, and it's a better safety net if the system does fail. Now, if the basal rates are set too high, what you're going to notice right on the home screen or in the uploads is that that system's going to constantly be pulling back and decreasing to try to prevent hypoglycemia. Now, you may not see a low. In this case, they are getting a little bit low, but the system may do a good job preventing the low, but we would know that the system's having to work really, really hard to prevent those lows. So that would be a situation if that's happening consistently, we see kind of actually a negative insulin on board because it's pulling back, pulling back, pulling back, then we know we need to lighten up on those basal rates a little bit. And then the reverse is true, is if the basal rates aren't strong enough, let's say you've got a kiddo that's had a big growth spurt and you're looking on the reports and you see it rising, 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 rising constantly, then we know that that system's having to work really hard, probably because the basal rates aren't set strong enough, and we could go and tighten those up a little bit more. What tends to happen here if the basal rates aren't strong enough is they may find, because every basal increase above that baseline counts as insulin on board, they may find that they're going in to try to give corrections and the system's telling them that they have too much insulin on board. And so they get these stubborn highs that the system doesn't allow them to correct for. So that's another sign that those basal rates may not be strong enough. Really important, though, that when you're seeing all these basal increases, please ask about the entry of carbohydrate. Many people discover that they can get away with snacking and eating certain amounts of carbohydrates, and the system does a really good job of, covering that off. So if this is actually a case of snacking, throughout the morning here and having small amounts of carbs, then it's not necessarily a basal issue. So make sure you ask that question there. So now let's talk about the insulin sensitivity factor. So the ISF in this system, it's really important to think about that it's actually not just used for the bolus calculator, it is also used for determining those increases and decreases to basal. So traditionally, we think of a correction factor as, how much does 1 unit drop the blood glucose level? But now what we also have to think about is when that system is predicting a glucose below target, it's also using the ISF to do the reverse math and figure out how much insulin do we need to subtract in order to get that glucose level back up to target. And this is not true of all systems. Some of them just use this just strictly in the bolus calculator. But that is why, many of you, I think over half of you picked this as the strongest lever, that's 100% why this is the case. So having a correct ISF is actually helpful for highs and lows with using a looping system. And if somebody has this set incorrectly, they're very likely to end up with roller coaster blood sugars. So when you see those ups and downs, and it's a lot of variability, I would absolutely check that ISF first. Same thing, if you have someone that's really struggling and they want to make the system more or less aggressive, if you're unsure what to move, so let's say that basal, you're not totally confident if it's, sometimes it's higher, sometimes it's lower, then I would definitely start with the ISF. It's your safest starting point, but definitely recognizing all those settings still play a role. Now, the carb ratio, well, this is important to, get it again, roughly in the right ballpark before starting loop. When you're really doing an assessment of, is that carb ratio effective or not for somebody that is looping, what we want to see is where is that glucose landing 3 hours after the meal? They should be back in, if it's correct, they should be back into range at about that 3-hour window. And why we use 3 hours instead of waiting that entire, say, 4 to 5, 6-hour duration of insulin action is that we know that we can go more aggressive with the carb ratios on these systems, and it does a really good job at accounting for that tail in that kind of 3 to 5 hour window at the end. So if we can get them back to target here, then they're going to be doing most likely quite well. And for that reason, we do tend to see people go more aggressive with their carb ratio on this system than they would without automation. So that would be something that if somebody were to go off of closed loop, maybe something that you might want to weaken, because chances are they will have kind of strengthened this over time. So let's take a quick peek here at what delivering a meal bolus looks like. This has changed a little bit on the latest version, but the same concepts are all in here. But what you're going to see, is that they're going to go in and they're going to enter their grams of carbs. And there is an option here to change the time. So it will default to the current time. But say we had someone that forgot to bolus, or the kid comes in and boluses after he had the snack. You can actually, I could change this time to 11:30. I could change this to 10 a.m. And what that's going to do is it's going to adjust and not give you the full bolus, but it allows those carbs to be accounted for by the algorithm, so it can make adjustments accordingly. The other really nice thing in here is that you can actually adjust the food type. So this taco is a mixed meal, and they're saying those carbs last in the system for about 3 hours, but you could also change it to being something high glycemic index is the lollipop. It goes into the system much faster, or something more slowly absorbing like a pizza. And again, the algorithm is going to take care of the math for that, and it's going to track those carbs a little bit differently so that it responds better after those meal times. So a really cool, unique feature to this system. Also, once they get into this bolus recommendation, they 100% have the ability to override that. So, if there's exercise, for example, they can cut it back. If it's something they, for some reason, want to increase it because they're insulin resistant, they do have that option as well. So that's their choice. And then they would go ahead and deliver that bolus. Okay. So the R is for, when does that system leave closed loop? Basically, it's if they lose communication with the sensor. And again, goes back to those program basal rates. Obviously, we need to be having those proactive discussions around DKA. If the CGM isn't working, there are reasons why we can go out of closed loop. Generally speaking, though, most of the time, people do tend to do better getting that help from the automation. Now, the educational points, I'm going to, point you to go into the user guide. We go into each of these in quite a bit of depth in there. And I think we've had a lot of education on, AID, best practices overall, especially as we've seen this kind of explode in the type 1 diabetes world. Probably the biggest thing that I see people continue to struggle with, they kind of get their heads wrapped around the core functioning of these systems, and then they get stuck with exercise. And this is probably, the biggest mind shift change is kind of learning how to exercise as close to target as possible. Because when a system ramps up, that creates a lot of challenges. And the one feature I would definitely encourage you to have a conversation with your families about is, are they using the temporary override? So that is this little heart icon on their home screen. And basically, they can set up their own extra profile that adjusts their overall insulin needs. So in this situation for a ski day, we're going 70%. It's actually going to reduce the basal, the bolus, the correction, all of the insulin doses down to be 70%. And then they can adjust that range as well and the duration. So this is a really, really fantastic feature that is worthwhile playing with. Here's somebody, setting it up for long runs, a short run, activity in 2 hours, and different things. Here's a post-exercise even in here. So there's lots of ways this can be customized, very user-friendly. Okay, so before I wrap up, I will, highlight here that the sensor and the sharing capabilities. So for sensor use, one of the big highlights of these systems is that they're very quick to adapt to new technologies. So for example, when G7 was launched, looping was G7 compatible almost out the get-go. We worked really, really hard to expand that compatibility. And then as far as sharing goes, that's really important in the clinic setting. We do have two choices here where there's Night Scout, which is kind of the original, that original group created this Night Scout. Many people do choose to use Night Scout. That does give remote monitoring and even other remote capabilities. But there also is Tidepool. And for a long time, people were just using Night Scout because it was the only system that allowed pump settings to be visible. But I will happily share that, Tide Pool now actually does show those pump settings as well. Tide Pool is free for the users, and actually, I find that it does look the most similar to some of the reports we use from other systems. So you do have the choice of either of those, and we do break these down in the user guide. Again, in the user guide, this does walk you through kind of how to go through looking at those reports, what to look for, kind of rules of thumbs for the different pump settings there as well. And, here's just a quick snapshot. So again, very similar to what we see in our commercial systems. You can see those basal increases, decreases. You can see the boluses, the carb entries. Here's the glucose, insulin data. All of that is in there. Night Scout is, all that information is there and more. It's probably the most detailed reports in Night Scout. So we do see a lot of families choosing to use this. Again, that information is in the user guide. Probably the biggest difference is that for Night Scout, they are going to give you a web address for their specific Night Scout account, and you'll just put that in your internet browser and you'll get into the reports. Whereas with Tide Pool, you're logging in more like, for example, using Gluco, very similar. So, at the end of the day, what's our goal? Right? Let's not, get too caught up in the weeds of all this. We're absolutely trying to help them optimize their glycemia, minimize lows. Is usually, very front of mind, but also making sure that we're helping them minimize their burden. And, it can be easy in a system where you can customize a lot for people to really get in the weeds of this. But let's make sure that we're, taking a step back and going, okay, the idea of going on looping is to make your life easier, right? To make your child's life easier, mom's life easier, dad's life easier, whoever that caregiver is. So making sure that we're coming back to that so that we're optimizing the settings around that. This should not be more work. It should be less work, absolutely, for them. So I will send those links out. I will also share, I do not have my website up and running yet, but I am absolutely working on some resources right now around navigating all of these systems that we have available today. So I have many versions of tables on which settings we adjust on different pumps. So I look forward to launching this hopefully very soon through Type 1 Journeys. You can follow me along there. But for the sake of today, thank you for your time. And I'm happy to take some questions. I can stay around a little bit longer if people are still there. But thank you again, Leslie, so much for having me.
Thank you so much, Alana. And I think the attendance and questions already shows, how much people are interested in learning more about DIY looping. So if people are okay staying a few minutes, I know some people have to drop off, but if people are staying a few more minutes, we're fine to do that. And I think, Alana, can you see the questions in the Q&A there?
Let me.
Or I can read them out as
Sure,
well.
maybe I'll get you to read them up while I pull them
Okay,
up.
so the first one is, what are your thoughts on sending patients to BC Diabetes to start on loop?
Yes, great question. Really great question, because that's really expanded over the last couple of years. So at the time when we did the position statement, that was only just starting. And we really carefully thought this one through. And we still very much do stand by that the person is really going to get the greatest benefit if they go through the steps of learning how to build that app themselves. Because now you're taking ownership. It's that autonomy. They're forced to get involved in that DIY community. You basically have to join that Facebook group. You're getting into the loop docs. You're doing the education as you go versus having that app kind of loaded for you. That being said, I absolutely recognize that that's a barrier, right? That is going to stop some people from using that. And so I would say that probably some people can do well, and many people have done well going through BC Diabetes. What they've done there is amazing. They're ultimately, trying to make this more accessible to people. But I would make sure that you beforehand, do some of this pre-education, encourage people to get in the Looped Facebook group so that they are learning the ins and outs of how these systems work, how they might have to rebuild this themselves, if they need to at some point before going and having it done for them.
Great. So can you see the questions in the chat, or I'll read the next, or the Q&A. It should be in the Q&A. If not, I can read them out.
Yeah, can you confirm for Loop, is it temp basal or auto boluses? Is one question from Carrie. So yes, so basically they're going to choose the temp basal branch or the auto bolus branch. That auto bolus branch basically is happening at that every 5-minute increment. So if you think about the system determining how, let's say a situation, the prediction is a high glucose in the future. That's what this would be. So every 5 minutes, it's figuring out how much extra insulin does this person need. If it's working as temp basal rates, it's basically dividing that extra insulin out over temp basal rates. I think it's like 17% or something. So they're going to get it more slowly. Whereas if they switch to the auto bolus branch, what it does is it calculates, okay, how much extra insulin is needed, and it actually gives 40% of that dose in that 5-minute increment, and then it reassesses it at the next 5-minute increment. So it's just going to be more aggressive, a little bit faster in that auto bolus branch, but ultimately getting that same amount over time. So we absolutely recommend, or the recommendation on Loop Docs, and this is where I love people going through the steps of this, is when you read through, what am I going to choose? It says, hey, we recommend that using the temp basal side is the safest at the beginning until you're very confident that that correction factor is working, that your blood glucose is responding to those increases and decreases in insulin appropriately before you go and you make it into that more aggressive auto bolus way. And many people never go to the auto bolus. A lot of people continue to just use the temp basal. Hope that answers that. Can you talk a little bit more about how to read data from Night Scout? What loop adjustments look like and where it is suspending and giving extra? So that is tricky to do without that could be a whole seminar, but really what you're looking for in Night Scout is, I highly recommend you go through those daily reports and again recognize that baseline basal is the program basal rates. Is the system tending to increase above or below? And you're going to have a pretty good sense of, or is it a mix? And it should be sometimes high, sometimes lower, sometimes higher, sometimes lower. That's how we know that those basal rates are working well. And then what you want to do is go and see, okay, is there hypoglycemia? Okay, if a low has happened here, what happened before? Is the low happening, after the system corrected? Well, then maybe that correction factor is too strong, right? So it's really walking through it, go through piece by piece, go across the day, do this with the families you're working with, because maybe something else was at play, exercise, all those other pieces like looking at pump reports, but just kind of day at a time is going to be the most effective. Okay, someone else I see here. Is there a benefit to having a BG target range versus a single value? I think that's going to be very individualized. I know some people, really are trying to get as tight as they can. So they're saying, hey, if I'm a little bit over 5.5, I want the system to bring me down a little bit more. Whereas some people are saying, actually, I don't want it giving me extra insulin if I'm 6.5. I would rather, wait until I'm above a certain amount. It will be correcting to the midpoint if they do set a range though. So that's something kind of reassuring to know. Very personal choice. I think when you ask people, it's amazing how they're like, oh, I would want it this way. Have that conversation with them. Okay, here is what is a good rule of thumb for calculating ISF and insulin to carb ratio. I heard that the ISF is typically set weaker than the usual 100 over TDD or 90 over TDD. So that's a really fantastic question. And I think what's tricky to say about these rules of thumb is it's all based on that total daily dose of insulin. So your first question is that total daily dose of insulin accurate? And usually with automated insulin delivery, that system is getting pretty close to an accurate TDD because it's working as hard as it can to get them into range. If they're still experiencing a lot of hyperglycemia or hypoglycemia, you may actually need to adjust what TDD you are using in those calculations. So that's step one. Based on the glucose patterns, right? I still always, what is happening in response to food? Go tighter until you get where the glucose is working. Same thing with, yes, that correction factor in this system does tend to go a little bit weaker. Carb ratio stronger, correction factor a little weaker, but the numbers don't lie. So just follow what you see in those pump reports. Okay. Maybe I'll just take one more here because I know we're getting tight for time. So what's the recommended max basal rate? Example, should it be 3 to 5 times the set basal? That's a really good question. So if you go through the loop docs, they tend to say that most people, for most individuals, kind of between 3 to 5 times that maximum basal rate tends to be the max where they would set that. Again, keeping in mind that it's every 5-minute temp basal rate. So that doesn't mean we need to get scared about, okay, if that person's basal rate is 1 unit an hour, and it's set at 5 times the max basal, that's 5 units an hour. Well, it may only set that for 5 minutes, right? And it gets canceled after 5 minutes. It has to set a new one and reconnect with the CGM. So that is where they're going to get almost more of that bolus-like behavior when that max basal is set higher. So I wouldn't start at that to begin with, but certainly people do tend to work up towards that 3 to 5 times as they get more comfortable with it.
Thanks so much, Alana. I wonder, just for the other questions, we can connect offline, and maybe if you provide a short response, we can include it in the email we'll send with the resources and everything.
Absolutely. You got it. You got it. Great questions, everyone. Thank you.
Yeah, thank you everyone for I know some people were able to stay a little bit longer. Thank you so much. Just before we sign off, again, thank you so much, Alana, for a really great, informative, information-packed presentation today. And just a reminder to everyone that you'll be getting an email reminding you to complete the evaluation survey. So I'd really appreciate if you could do that. And just a reminder about some of the other events we have coming up in the next few months. And again, thank you so much. And I hope everyone has a great rest of your day. And hopefully spring is coming for all of us in Canada soon.
Fair enough.
Thanks so much, everyone. Thanks, Alana. Thanks, Mita.
Thank you very much.
Thank you,
Bye.
everyone.